is a GE junction cancer, and this is a very large gastrohepatic node, which is centrally necrotic. Best use of pancreatic cancer is in initial looking for distant disease. You can also use it for treatment response, preoperative following chemoradiation, and also for treatment response following melanoma. And this is another creating distant metastases for this patient. Response to neoadjuvant, it should not be confused with metastatic disease. For recurrence and restaging, again, conventional techniques, carcinoma is fairly low, and it's worth just staging gastric carcinoma. Again, the value of PET is equivocal over CT. Endoscopic ultrasound is are insensitive for regional lymph nodes, probably because the metabolic activity is fairly low typically. PET CT may play a role in fundus of the stomach that's metabolically active, and also diffuse fluid. There are some new tracers being developed with FDG down non-metastasizing tumors, but there is overlap. Intraductal papillary mucinous neoplasms, or IPMNs. There is an NIH trial underway. The current evidence suggests that it may help in some circumstances in distinguishing benign or malignant, but you can't stop following these lesions by CT. And I have not used PET to try to characterize. So this one looks quite diseased. That is a abnormal pancreas in a 72-year-old. It is sausage-shaped. There's a little bit of fuzziness around it. He also had multiple lymph nodes were elevated. They put him on steroids, and this was a follow-up scan showing resolution of the findings. This isn't fluid. These are all mucinous deposits around the stomach, around the gallbladder, and this is mucinous tumor within the omentum here, and also within the mesentery. Tumor are usually hypermetabolic. However, the versus adenoma, that's not my experience, I have to be honest. Malignancy with less than one being benign, but it was one. I have also seen the oncocytic variants that were negative. You can see you can get increased uptake in the adrenal glands, the rapid washout, the same as you do with CT. There's often a persistent rim of enhancement, and on DWI, a high intratumoral signal is suggestive of HCC. Is a moderately or well-differentiated HCC. It looks just like the rest of the liver on PET. You may miss it completely. If you do see uptake, it is basically negative. This is from the distant rim of activity around the lesion, and that can persist for a number of months. But if you are up increased uptake, that suggests recurrent disease. This patient had hypermetabolic tissue up here in the neck. Yttrium 90 microsphere radioembolization is sometimes difficult to follow in terms of therapeutic of PET over CT or MR. It may alter